Hi and welcome back. Today we will discuss a few more topics in clinical pathology. We will be discussing the red cell indices, that is MCV, MCH and MCHC. We will also discuss erythrocyte sedimentation rate. We will be discussing examination of bone marrow, that is bone marrow aspiration and biopsy. We will also talk about a few tests for hemostasis, that is bleeding time, clotting time and the like. And finally, we will finish it off with blood grouping and RH typing. Okay, let's dive into the discussion. Okay, first let's discuss about the erythrocyte indices or red cell indices. Red cell indices are some calculations based on RBC count, hemoglobin and packed cell volume, which we discussed in our last class. There are some calculations based on RBC count, hemoglobin and packed cell volume, which provide some quantitative information about the red cells. It was Winthrop who introduced these calculations, so they are also called as Winthrop's constants. And these calculations are mainly used in the classification of anemia. The three red cell indices are: number 1, mean corpuscular volume, that is MCV; number 2, mean corpuscular hemoglobin, that is MCH; and number 3, mean corpuscular hemoglobin concentration, that is MCHC. We will see each one separately. Talking about mean corpuscular volume is the average volume of all red cells. It is calculated with the formula MCV, mean corpuscular volume, is equal to PCV, that is packed cell volume, divided by the number of red blood cells, that is RBC count, and it is expressed in femtoliters. Mean corpuscular hemoglobin is the average amount of hemoglobin in all red cells, and here the formula is MCH is equal to hemoglobin by RBC count, that is red blood cell count. This is expressed in picograms. MCHC or mean corpuscular hemoglobin concentration is defined as the concentration of hemoglobin in an average red blood cell, or that portion of that average red cell composed of hemoglobin. Here the formula is HB by PCB, and this one is expressed as a percentage. Now coming to the normal values, the normal value of MCV is 85 plus or minus 9 femtoliters, and the average value of MCH is 29.5 plus or minus 2.5 picogram, and the average value of MCHC is 33 plus or minus 2%. And coming to its clinical significance, as I told you, this is mainly used in identifying the type of anemia. In macrocytic anemia, MCV is increased, MCH is slightly increased, and MCHC is normal or decreased. Whereas in microcytic hypochromic anemia, all the three are decreased. In condition of spherocytosis, MCV is decreased, but MCHC is elevated. And remember, spherocytosis is the only condition where MCHC is elevated. In most other conditions, it is decreased. Now moving on to our next topic, that is erythrocyte sedimentation rate. When venous blood is placed in a vertical tube, the red cells sediment to the bottom due to formation of prolix. This length of fall to the top of the column of RBC in a given interval of time is called ESR or erythrocyte sedimentation rate. Three stages are seen in this fall. The first one is prolix formation or aggregation. Next is settling or sedimentation. And the third one is packing. In the first 10 minutes, the RBCs come together in Rolex formation. They are packed like piles of coins, one on top of another. For the next 40 minutes, they settle at a constant rate, and this stage is called settling or sedimentation. And in the final 10 minutes, the sedimentation slows and the cells pack at the bottom of the tube, and this is called packing. ESR can be calculated by a few different methods. The commonly used one is modified Westergren method. Here, a Westergren tube and a Westergren rack is used. Westergren tube is a straight pipette 30 cm long with an internal diameter of 2.5 mm. It is calibrated in millimeters from 0 to 200 and it can hold about 2 milliliter of blood. The function of the Westergren rack is to hold this pipette vertical. The anticoagulant used here is sodium citrate and anticoagulant blood ratio is 1:4. There is 1.6 ml of blood is collected and 0.4 ml of anticoagulant is used. This maintains the 1:4 ratio. Coming to the procedure, the anticoagulated blood is drawn into the Westergren tube up to the 0 mark. The outside is wiped clean and the tube is set up in the rack in a perfectly vertical position. And it should also be ensured that there should be no air bubbles in the blood column. A stopwatch or clock is started and the reading is taken at 1 hour. The reading corresponding to the upper layer of the RBC column in the pipette is taken. Coming to the Winthrop's method, here the procedure is more or less same. The only difference is the tube used here is Winthrop's tube, the tube which we used for PCB, the Winthrop's PCB tube. Coming to the micro ESR method, here again the procedure is more or less similar, but the tube used is plastic ESR tube, which is a 230 mm long one with 1 mm internal bore, and this can be filled with blood of about 0.2 ml. The advantage with this is only small amount of blood is needed, and so it can be used in infants and small children. Coming to the normal values, for men it is about 15 mm per hour, and women it is slightly higher, that is 20 mm per hour. Coming to factors affecting ESR, both physiologic and laboratory factors affect ESR. The physiologic factors affecting ESR include increased plasma fibrinogen, cholesterol, globulins, etc. When these things are increased, ESR increases. Same way, when there is a drop in RBC count, that also increases the ESR. On the other hand, when there is increase in number of RBC or when there are abnormal RBCs, ESR is reduced. ESR increases with age, and it also is increased in women, as we saw already, and it is also increased in pregnancy. Some laboratory factors also affect the ESR. ESR ideally should be done at 20 to 25 degrees Celsius. Any variation in this can affect the value of ESR. The same way, the test should be done within 2 hours of drawing the blood. Any extension in time will affect the value of the ESR. Tube factors like length and diameter of ESR tube and tilting of tube can also affect the value of ESR. So all these conditions should be kept in mind while interpreting the value of ESR. Coming to the interpretation, ESR is mostly increased in diseases like chronic inflammatory conditions. Example, TB, that is tuberculosis, rheumatoid arthritis, etc. Moving on to a next topic, that is examination of bone marrow. Talking about the indications for the examination of bone marrow, this is usually done to evaluate any increase or decrease in blood cells or in conditions like leukemia, both acute and chronic leukemia, or to evaluate the iron content of bone marrow, or it is also done to evaluate or diagnose the involvement of bone marrow in tumors, or for the confirmation of infections like tuberculosis. Bone marrow study can be done either by bone marrow aspiration or bone marrow biopsy. The common site selected is either the sternum or posterior superior iliac crest. The common instruments used for aspiration are Sala's needle or Jamshid's needle. These are special types of needle which has two parts, the outer needle and the inner stillet. The instrument used for biopsy, that is bone marrow biopsy, is true cut needle or Jamshidi bone marrow biopsy needle. Coming to the method, bone marrow aspiration is always done in a hospital with due precautions. Obviously, asepsis is done. Local anesthesia is administered to the selected site. Then, needle is introduced into the cortex with a firm pressure. And after securing the needle in position, the stillet is removed. A 10 cc syringe is fitted to the needle and a firm aspiration is done. Now, the patient will experience an acute pain called suction pain. After that, the needle is gradually recovered and complete hemostasis must be ensured. The aspirated material is blown to a glass slide and smears are made in quick succession. The smears should be made without any delay. That should be taken care of. The smears are air dried and stained with Romanowski stains. Coming to the interpretation, the smears are analyzed for number of cells, the morphology of the cells, pattern of maturation, the erythroid-myeloid ratio, the presence or absence of abnormal cells, etc. Moving on to the next topic, that is test for hemostasis. What is hemostasis? I have already explained, I think, in one of my previous videos. It is clotting of blood. The laboratory tests for hemostasis can be categorized into three categories. One is screening tests. This category includes tests like complete hemogram with blood cell counts. The second category is special tests, which include tests like bleeding time, clotting time, clot retraction time, clot lysis time, activated partial thromboplastin time, prothrombin time, etc. These are the subject matter of our discussion today. And the third category is confirmatory tests, which include tests like platelet function test, quantitative assay of clotting factors, etc. Moving on to the first test we will discuss today, that is bleeding time. Bleeding time is defined as the time taken for bleeding to stop after an injury. Okay, it is the time taken for the bleeding to stop. That is the time taken for the formation of primary hemostatic plaque. This test tests the platelet and vascular integrity, because first stage is formation of platelet plug. Yes? So this test tests the platelet and vascular integrity. As far as bleeding time is concerned, commonly two methods are used. One is Duke's method, another is IV and template method. In Duke's method, the earlobe is punctured. This is not a preferred method because there is pain and also there is complication of hematoma. The second and preferred method is IV and template method. Here the site selected is forearm. The forearm is cleaned with spirit and blood pressure cuff is tied to the arm and inflated. Using a special blade called template, two incisions are made parallelly. When the blood appears in the wound, the timer is put on and the time at which bleeding stops is noted for both the cuts. The average is taken as the final value. The normal bleeding time is 2 to 6 minutes. Any prolongation in this value indicates platelet defects or conditions like von Willebrand factor deficiency, or it can also indicate taking of drugs like aspirin. Coming to the second test, that is clotting time. Here, this is defined as the time taken by freshly drawn blood to clot. This checks the integrity of intrinsic and extrinsic pathways of clotting. Bleeding time checks the integrity of platelets and vascular structure. This clotting time checks the integrity of intrinsic and extrinsic pathways of clotting. The method used is three test tube method or Lee and White method. In this method, the venous blood is taken by two syringe method and the timer is started as the blood appears in the second syringe. 3 ml of blood is withdrawn and each ml is added to 3 clean dry test tubes placed in a preheated water bath. The water bath is maintained at 37 degrees Celsius, that is our body temperature. The tubes are tilted every 20 seconds and time taken to form a clot in the first tube is calculated. The time taken for other tubes is also noted and the average value is taken. The normal value here is 10 to 20 minutes and any prolongation occurs in conditions like deficiency of clotting factors, DIC, that is disseminated intravascular coagulation, etc. Coming to the next test, that is clot retraction test. A normal blood clot undergoes a retraction to about 50% of its original volume by the end of 2 hours. This is due to the presence of platelet contractile protein called thrombostatin. Any deficiency in this protein leads to defective clot retraction. Coming to clot lysis time, a normal blood clot does not dissolve up to 48 hours. Accelerated lysis indicates overactivity of fibrinolytic system. Coming to activated partial thromboplastin time, this test measures the integrity of intrinsic pathway. It is the time taken for the patient's plasma to clot after addition of partial thromboplastin. This addition activates the intrinsic pathway and allows the sample to clot. A normal activated partial thromboplastin time is 25 to 40 seconds. Any prolongation indicates deficiency of intrinsic pathway factors like factor 12, factor 11, factor 9 and factor 8. Prothrombin time, on the other hand, tests the integrity of extrinsic and common pathways. It is the time taken for the patient's plasma to clot after adding complete thromboplastin. This activates the extrinsic pathway and allows the sample to clot. Normal prothrombin time is 12 to 14 seconds. Any prolongation occurs in deficiency of clotting factors like factor 7, factor 10, factor 2 and factor 1. Remember, most of these factors are vitamin K dependent factors. With the help of APTT, that is activated partial thromboplastin time, and PT, that is prothrombin time, the exact factor deficiency can be detected and this can be confirmed later by doing quantitative assay for the appropriate factor. We will leave test for hemostasis here and move on to our next topic, that is blood grouping and RH typing. I will not discuss about the ABO blood groups here because you must have already learned that in physiology. What I will discuss here is how these blood groups are identified in laboratory. The reagents used for blood grouping are antibody reagents, which are monoclonal antibodies directed against particular blood group antigens. There are also red cell reagents, which consist of pooled ABO type red cells, and supplementary reagents, which are generally used in testing subgroups, that is anti-A1 lectin, anti-H. These are the supplementary reagents. Now coming to the procedure, the commonly used method is the slide or tile method. This is used generally for emergency blood group determination and also in outdoor conditions. This is not a very sensitive test and it has another disadvantage that it dries very quickly. Here in this method, the slide tile is labeled to identify the cells. A drop of reagent antisera is kept on the slide and a drop of a red cell suspension is added to it. Both of them are mixed well with a separate applicator stick. And the slide is gently rocked and looked for visible agglutination. Normally, the results are read within 2 minutes. The pattern of agglutination is shown here in the picture. The well which shows the agglutination is read as the blood group of individual. For example, if agglutination occurs in the well with anti-A antibody, then the group is A. If the agglutination occurs in the well with anti-B antisera, then the group is B. If agglutination occurs in both, then the group is AB, and if there is agglutination in no well, there is no agglutination in any well, then there is O blood group. Another method used is tube method. It has a few advantages. It does not allow the drying of the sample and ensures proper incubation of the reagents. There are two different forms of tube testing. One is immediate spin technique. Here, 3 clean dry test tubes are taken labeled as A, B and O. 2 drops of antisera is added to the pre-labeled tubes accordingly. There is anti-A is added to the tube labeled A. 1 drop of red cell suspension is added to all the 3 tubes, and the test tubes are centrifuged for 15 to 20 seconds. The agglutination is read visually. In reverse typing, the serum sample is used for testing. The serum separated from the patient sample is taken in the tube, and to this is added known cells. There is known type of cell, there is A, O or B type of cell. The tubes are incubated at room temperature and then centrifuged to look for agglutination. And this is also finally checked under the microscope. Here, the interpretation is slightly different. If agglutination occurs in the tube where known A type of cells are dropped, then it means the serum in the patient sample contains anti-A antibody, and therefore the sample is B type. The same way, if agglutination occurs in B cell added tube, then the antibody in the serum is anti-B, and therefore the blood group is A. And this is likewise. The problems usually encountered in blood group testing include poor reagents, improper technique, or weak antibodies. For example, in immunosuppressed patients, there might not be enough antibodies to elicit agglutination. Coming to compatibility testing, this refers to a set of procedures required before the blood is issued from the blood bank as being compatible for transfusion. Cross-matching is part of compatibility testing. There are 2 forms of cross-matching, major cross-match and minor cross-match. Major cross-match consists of mixing of the donor red cells with the recipient serum. Here the method used include immediate spin method, saline room temperature method, albumin addition, indirect antiglobulin, etc. Coming to minor cross-match, it consists of mixing of recipient's red cells with donor serum. Both these are done in cross-matching. Okay, more than enough of clinical pathology. We will wind up our unit of clinical pathology here. We will start a new unit, that is laboratory pathology, in our next video. As usual, I have provided PDF notes in the description, and you can contact me if you need any help. I have provided the mail ID also in the description. Do keep the channel subscribed for more videos. Until we meet in another video, thanks for watching. Bye.